Hello everyone. I am Dr. S.S Das Gupta, Registrar in the Department of Cardiology, Narayana Hospital, Jessore Road. We have with us Dr. Gaurav Agarwal, Consultant Cardiologist at Narayana Hospital, Jessore Road. Hello sir.
Hello.
Today we are going to discuss, sir, about a very important and very less discussed about topic is heart failure.
Yeah.
Sir, what is your take on heart failure? Can you just simplify and define heart failure?
See, as a cardiologist, we define heart failure as the inability of the heart to, pump the blood forward. If I speak in common layman terms, so our heart is nothing. Our heart is just a group of muscles, it's a group of peshi, if I speak in Bengali. So let's say this is that our heart and this is this group of muscles. So with every contraction, the heart contracts like this and then it relaxes back like a spring. So here you see this is a spring. So this spring, it will work both ways, right? It will coil and then it will recoil. So both the parts are important. That is, the heart has to contract, that is, the spring has to coil and then it has to recoil. So heart failure can happen in both ways. Either the heart loses its pumping capacity, that is, it loses its contractile capacity, or it loses its relaxing capacity, that is the recoil capacity. So the first entity where the heart becomes weak and loses its contractile capacity, we call that as heart failure with reduced ejection fraction. And the other domain, that is where the heart loses its relaxation capacity, that is recoil capacity, that we call as heart failure with preserved ejection fraction. Now what is ejection fraction? So ejection fraction is nothing. Let's say you have 200 ml of water in a jar and then 100 ml of that water gets disposed by that jar through a machine. So remainder will be 100 ml. So 100 ml it has pumped, 100 ml is remaining. So 100 upon 200, that is 50%. So that is where we calculate ejection fraction. So normally our heart pumps around 60 to 70% of the blood which it receives with each cardiac cycle. So that is normal ejection fraction for the heart. So when we call heart failure with reduced ejection fraction, it is when the ejection fraction reduces to below 40%. And when we call heart failure with preserved ejection fraction, that is when the ejection fraction, that is the pumping capacity of the heart, is preserved. That is, it is more than 50%, but the recoil capacity, as I said, is disorganized and it is not relaxing properly, and that is why it is not receiving the blood which is coming back from the lungs, and that leads to difficulty breathing to the patients. So that is, in a simplified way, how do you define heart failure, or how do you explain heart failure?
Right, sir. The question is the epidemiological distributions. I mean, we are not just this is a very right now a common problem that we see in our OPDs. Can you just define it?
Right. So as an interventional cardiologist, we keep on talking about angiograms, angioplasties, pacemakers and whatnot. We keep on talking about lot of interventions. But usually we do not speak upon heart failure, which is actually the most common presentation in cardiology, if you ask me. Okay, so there are so many patients with undiagnosed dysfunction of the heart, reduced function of the heart, plus patients who have, with gradual periods of time, they will complain of worsening capacity of breathing difficulty, worsening breathlessness. They will have swelling of the legs, swelling of the face, abdominal distension. So
those are signs and
symptoms of heart failure.
Yes.
But no one, in the peripheries and in the extreme parts of our country, no one tends to look upon their heart. Whereas this is one of the most common reasons for this kind of presentation. So that is where I want to underscore the importance of cardiac function and heart failure. So if you see, if I talk to you about a cancer patient, let's say you ask me what is the 5-year survival rate of a patient with kidney cancer or a patient with lung cancer, it is more than 50%. Whereas if I talk to you about a patient with heart failure who is in functional class 2 or 3, his heart 5-year survival rate is less than 20-30%. So heart failure is a much worse and a much common enemy or a disease entity rather than cancer, rather than many other disease modalities which we keep on discussing about. So this is where I want to emphasize that heart failure is a very large burden, and if at all we diagnose it, we catch the patients at the right time, we can, give them the possibility of best medical therapy as well as advanced therapies in the form of devices or in the form of angioplasty, bypass surgery, as and when it is needed.
Sir, definitely I'll ask you one question here. What will you suggest for young doctors like us who are seeing patients with breathlessness outside? We often confuse with a respiratory distress patient comes and we think it is more a pulmonary component rather than a cardiac component. How will we understand that the patient is more into the cardiac side?
So here you will have to start from the basics itself. You will have to see whether the patient is a male, female, what is the age group of the patient, what are the background risk factors. So we all know the conventional risk factors for heart disease, diabetes, like blood sugar, uncontrolled blood sugars, uncontrolled blood pressures, elevated levels of cholesterol. So in this background, or let's say any patient who has a background history of any heart disease. So if you try to elicit upon this history, elicit upon these points, then you will find that maybe there is a connecting link where you can find that the patient has had some cardiac event. Or let's say if it is a patient with lung disease, then that patient might give you history like his predominant symptom rather than breathlessness, it is cough. So most of the times patients who have respiratory disease, that is lung disease, those patients, their predominant symptom is cough followed by breathlessness. Whereas in patients with cardiac disease, the predominant symptom is difficulty breathing, that is breathlessness, and then they have cough. Particularly this cough worsens when they are lying down. A cardiac patient's difficulty breathing will be worsened when they are lying flat. Okay, because the blood tends to get pooled in the lungs and that causes difficulty breathing, particularly in the flat postures. Whereas a patient who is having respiratory illnesses, they will have this kind of symptoms predominantly throughout the day and worsens during the night, but they do not have any postural variation. Plus, this kind of symptoms will worsen during the cold seasons, that is winters, rainy seasons. Okay, this kind of thing with a respiratory disease will worsen. So that is how you can connect. Then a very common bedside modality which we have, that is chest x-ray, which all of us advanced doctors, we have forgotten this modality. A chest x-ray is more than enough to diagnose whether it is a cardiac etiology of breathing difficulty or a respiratory. Because respiratory etiology, you will have hyperinflated lungs will be full of air, and there will be some prominent markings. Plus patient can have pneumonic consolidation, whereas a heart failure patient will have lot of pulmonary edema, patches in his x-ray. And the most confirmatory investigation, which of late in the last 10 years, that is a gold standard, is NT-proBNP. This is a blood marker for heart failure. You can send it if it is available at your center, and that will confirm whether the patient is having cardiac etiology of breathing difficulty or a respiratory.
And we have the echoes also.
That is definitely.
Okay.
Yeah, another.
Okay. Sir, quickly we'll come down. You have said that early management is necessary. Sir, Can we know about the management protocols of this?
So before going to the management part, I'll just briefly speak upon how do you catch hold of these patients. So as I told, how do these patients present with breathing difficulty and swelling over the feet, abdominal distension. So whenever you have such kind of patients, the most basic thing, as we were discussing upon, you ask for common investigations like chest x-ray, electrocardiogram, that is ECG, echocardiogram. So a echocardiogram will actually, that is the most important modality for diagnosing heart failure. It will tell you whether the heart's function is reduced, that is the pumping capacity, the ejection fraction is reduced, or is it preserved. Let's say it is reduced, then you know that your diagnosis is confirmed, it is heart failure now with reduced ejection fraction. Let's say now you are talking about a patient who has heart failure with preserved ejection fraction, means his pumping capacity is preserved but his relaxation capacity is altered, is deranged. That also you can confirm with echocardiography, and then you can go ahead with a NT-proBNP, that blood marker. Once you have done this, then depending upon different features, you may get indications that the heart failure is caused because of certain number of causes. It can, for in our country, in a developing nation like India, still we have a very big population who is suffering from rheumatic heart disease. That is a common infection which occurs in the childhood, which also infects the heart and eventually causes long-term valvular heart disease. Okay, so that can be one possibility that is confirmed by echo. You can have heart failure secondary to blockage in the arteries supplying blood to the heart, that is ischemic heart disease. And then there can be some genetic causes, or it can also be in patients with vitamin deficiencies like thiamine deficiency, or alcoholics who are taking long-standing alcohol. So depending upon case-to-case basis, you will have to diagnose that particular way. And in a very advanced investigation now we have is cardiac MRI, which exactly pinpoints and tells us that what may be the etiology of this heart failure. So once you have diagnosed this, then we speak about management, as you were asking.
Yeah, sir. Generally, we have seen more patients towards a blockage in the coronary system that is causing a heart failure, a reduced ejection fraction.
Right.
So, can you throw some light about what is an angiogram, an angioplasty, and at the end, CABG?
Right. So basically, if you see the blockages in the coronary arteries, that is the blood vessel supplying blood to the heart, these blockages usually develop in patients with advanced age, particularly males who are beyond 40 years of age and females who are beyond 50 years of age, most commonly females who have attained menopause. That is, their monthly menstrual cycles have stopped. So this kind of patients with background of diabetes, hypertension, elevated blood cholesterol, these are the patients who will have blockages in the coronary arteries. So once you have such a patient who has unexplained reduced pumping capacity of the heart or unexplained heart failure, in these cases you should definitely go ahead for an angiogram. Angiogram is nothing but a minimally invasive procedure where we just go and check the blood vessels which supply blood to the heart. Let's say it is normal, then you are certain that this is not causing the cardiac dysfunction, some other reason. Then you can plan a cardiac MRI. Let's say there is blockages in the heart which you found on an angiogram. Then if there are multiple blockages and you see that these multiple blockages cannot be tackled with one or two stents, then you should go ahead and advise the patient coronary artery bypass surgery, because it has been found in multiple studies that patients who have significant cardiac dysfunction and multiple blockages, they tend to do best with bypass surgery, particularly when they are diabetic. And let's say patients who have one or two blockages in the heart and they have dysfunction of the cardiac function. So in those cases, you also go ahead with the angioplasty, that is placing a stent at the site of the blockage in the heart, and that stent will open the blockage, improve the blood flow, and slowly with time there is some possibility of marginal improvement of the pumping capacity of the heart, and that will reduce the symptoms of the patient significantly. But all this being said, there is definitely a certain subset of patients who tend to have continue to have long-standing dysfunction of the heart, means cardiac function will not come back to normal. In such cases, then we have to think of advanced therapies like devices like ICD, that is implantable cardiac defibrillator, because these patients with long-standing cardiac dysfunction, they are at a risk of sudden cardiac death. Most of us have had some or the other relative or some or the other incident where we heard that certain person suddenly died during their sleep or something like that. This is called sudden cardiac death. Okay, so these kind of things are very common in this subset of patients who have long-standing dysfunction of the heart and heart failure. So to prevent these, there are certain devices called ICDs and CRT, that is cardiac resynchronization therapy. So ICD, what it will do, it has nothing but it is like an electric shock which is given to the heart wire which is placed through a pocket made over the chest. There a generator is placed, a wire goes into the heart, and whenever such sudden cardiac event happens which can lead to sudden cardiac death, that is prevented by giving a shock to the heart through that ICD machine, and that will salvage the life of the patient. Similarly, there is another advanced machine called CRT-D that also does the same function, but that is placed in certain different subset of patients, which I don't think is possible to discuss here. But yeah, still, I would just like to emphasize that whenever your physician or your cardiologist says that you might require this kind of device for, improving or increasing the life expectancy, then you should consider that kind of device therapy. And lastly, I would just like to emphasize that there is now the role of cardiac transplantation. India is now developing, and it is now almost about to become a developed country. Now we have multiple centers where we are doing cardiac transplantation. So whenever the cardiologist feels that this patient is a good candidate for cardiac transplantation, then we should timely refer our patient for cardiac transplantation.
Sir, so we will end up with this topic of heart failure.
Okay.
I heartfully thank you for this enlightening topic discussed, and I hopefully it will be beneficial for so many patients.
Sure, definitely.
And we end up this session. Thank you, Dr. Gaurav Agarwal.
Thank you for considering.
Thank you very much.